I'm Dr. Nick Slamon. I'm a pediatric intensivist at the DuPont Hospital for Children in Wilmington, Delaware. In today's tutorial, we're going to go over a very important topic in pediatric critical care, and actually critical care in general, and that's airway readiness, or getting ready for a patient with impending respiratory failure to be intubated. In order to achieve the most success with this very difficult, anxiety-provoking procedure, you need to have the patient, the room, and all the equipment that you might need set up beforehand. The last thing you want to do when you have a patient with respiratory failure who's desaturating is to be looking for equipment that you didn't think you needed. Better to be prepared and have everything you needed ahead of time ready to go. What we'll start with is our pediatric patient, Ryan, laying here on the bed. And the first thing I want to talk about is positioning. So it's important to have the bed at a height that's good for you. So you don't want to have to stoop, you don't want to have to reach up, you don't want to have to reach too much forward for the patient. So it's nice to have the patient's airway somewhere where your hands can quickly make contact with the patient. You can manipulate his airway in a comfortable position without reaching too much or stooping too much. That'll really set you up early for success. So in addition to the bed height, it's important to talk about, especially in pediatric patients, their body habitus. So the size of their head relative to the size of the rest of their body is large. Having the head position optimal for intubation, and even a step before intubation, having the airway optimal for bag mask ventilation is really important. And to do that, what we do is we want to have the patient in what's called a gentle sniffing position. So they've kind of lifted their nose and chin as if they're smelling something very pleasant like flowers or perfume. Often in pediatric patients, to keep their head in that position, you have to rotate them back slightly and maybe put a shoulder roll, a rolled up towel or blanket under their shoulders to get them tipped back in that position. Or you may have to put a gel donut, if it's a smaller patient like an infant, under the back of their head to kind of lift them into that sniffing position and then keep them there. You don't want to have to kind of manipulate them during the intubation or during the bag mask resuscitation. You'd like their positioning to be the way you want it to be. In terms of equipment, now that we've talked about positioning, it's important to talk about and set up the basics. So here we have an ambu bag or a self-inflating bag. This is connected to oxygen here, the green oxygen outlet, and oxygen will flow through the bag. As you squeeze the bag to deliver a breath, the bag has tensile strength from the plastic and it'll reinflate. So this is commonly used in emergency rooms, but in pediatrics, we often use what's called a Mapleson bag, which is a flow inflating bag. So it looks like a green balloon. In order to get it to inflate, you have to hook it up to oxygen and have flow somewhere between 10 and 12 liters per minute. And then there's a valve on the side of the bag that you can adjust to deliver PEEP. But in this example, an ambu bag is fine to deliver breaths to a patient as you pre-oxygenate. You want to bring their saturation up to 100% if possible by delivering 100% of FiO2 through the ambu bag. Now, the next thing to talk about is after our patient's in that sniffing position, making sure that we have a mask that fits properly around the nose, chin, and mouth. Masks come in different sizes. Masks also have a reservoir here where you can inject air to make it a little bit softer or a little bit harder. But it's important to be able to have a mask that fits properly over the nose and mouth and makes a good seal. Now, in terms of the holding of the mask or how it's positioned on the face, we talk about the C and E position. So my index finger and my thumb are going to form the shape of the letter C around the mask, and then my middle finger, ring finger, and pinky finger are going to be along the hard, bony part of the jaw, not the soft tissues of the neck. We don't want to compress the jugular and carotid. We don't want to compress the airway. We want to stay away from the midline. So the E letters, these three fingers, middle finger, ring finger, and pinky, they kind of lay along the jaw and make the shape of an E. So we have our C, index and thumb, and our E. And using that positioning, we can often lift the patient towards us dislocate their jaw slightly and have their tongue, which is often obstructing in pediatric patients, fall to the back of their throat and get out of the way of the airway. So using one hand, if it's a smaller patient, or using two hands and having double C and double E is also possible. So let's demonstrate that real quick. So here's a double C and E position, and I can head tilt, chin lift the patient into position. I can use these E fingers to lift their jaw towards me, and I don't want to press the mask down on the patient. I want to bring the patient's face up to my mask. So in a double C and E, I'd obviously have to have an assistant here to bag for me, but most of my pediatric patients, I have hands that are large enough that I can one hand to bag them and one hand to position their. There's some other things that we want to have available. So we always want to have suction. What I have here is an example of a rigid Yankauer suction. That'll get hooked up to the suction trap on the front of the boom there. A rigid suction is great for really thick secretions. Just like in the dentist's office, you can kind of open the mouth, clean it out. What I don't have here is an example of a flexible suction, but that's almost like a flexible plastic tubing. It can fit down some of our airway adjuncts that we'll talk about in a minute. It can go down the nose into the posterior pharynx and suction there. But the thing about flexible suction is, depending on the caliber of the bore, the French number, it may get clogged up. So it's good to have both a rigid and a flexible suction at all times. Let's talk next about some of our airway adjuncts. We have some examples here: an oral airway and a nasopharyngeal airway. Nasopharyngeal airway, let's talk about that first. So that's going to go in the nair. You're going to put it all the way in. It has a central hole, as you can see. I can put that flexible suction down there. The idea behind the NP airway is to bypass the tonsils and the pharyngeal tissues that may be in the posterior pharynx that could be causing obstruction when you're trying to bag mask ventilate your patient. Now, why that's important? Again, it's something that's easy to get. You can lubricate it up with a little bit of jelly to make its passage easier. The patient doesn't have to be completely sedated to tolerate getting an NP airway put in, even though it's unpleasant. It's very quick, and most patients will allow you to do it. And picking the right size is important. So the bigger the caliber, the better, because we'll be able to get more mucus and more suction through a bigger caliber tube. But we'd like to measure appropriately. So we want to measure from the corner of the nose to the angle of the jaw. Sometimes the tube is the caliber you want for the nostril, but it's a little long. You may have to cut it with a scissor and make it a little bit shorter. But in this day and age, most NP airways are factory made to various sizes and lengths that you can usually find something that's good for you. Now, the next adjunct is an oral airway. Now, full disclosure, the patient that is awake is not going to tolerate an oral airway being put in. They're going to get nauseous, they're going to gag, they're going to retch, and they're going to spit it out. So your patient usually has to be pretty well sedated by the time you want to put an oral airway in. But these are great for people who have very large tonsils, very large adenoids, big tongue, lots of secretions. You may be bagging the patient and not getting any chest rise. You've repositioned them properly, made sure they're in the sniffing position, you've done an appropriate jaw thrust, and you still can't get chest rise. That's the time for an oral airway. So the placement of an oral airway is twofold. You can put it in backwards. You use your left hand to get the mouth open with a scissor technique. So index finger on the top teeth, thumb on the bottom teeth, and you open the mouth, put it all the way in, and then flip it around frontward. Other people will just get good mouth opening, go midline, and put it right in. And again, you see this has a hole in the center where you can pass suction through. Oral airway is really your best friend for an obstructed airway. Now, how do you size these? Well, we're going to go this time from not the corner of the nostril to the angle of the jaw. We're going to go from the corner of the mouth to the angle of the jaw. And you can see this one might be a little big for Ryan. This one measures out a little bit better. So the last couple things I want to talk about is the intubation supplies themselves. And while we're not going to intubate, we'll do that in another video, I do want to introduce some of the equipment. So here we have two different style laryngoscopes. We have a curved Macintosh blade. We have a straight Miller blade. Pediatrics is kind of notorious for using Miller blades because I think everybody gets introduced to intubation during the NICU rotation that they do as a resident, and most of the time there they use the 00 Miller blade. The blade sizes start at 00 for a micro preemie and go up to a 4. And each size, as you can imagine, is a little bit bigger and a little bit longer. The Miller blades are straight. They have a little bit of a curve on the end. They're fairly narrow. The design of the Miller blade is that you hold it in your left hand. You get good mouth opening. You insert it into the mouth and locate the epiglottis, that trapdoor above the trachea. You hook the epiglottis with the end of that blade, and you lift in the direction that my thumb is pointing towards the ceiling. And that should lift that trapdoor and expose the larynx and the vocal cords underneath. The Macintosh blade, which I favor, is a little bit wider and fatter, more curved as you can see, and it's got a little bit of a barrel tip on the end. And this is designed to be held the same way. You may have to really get good mouth opening because it's a little wider. You don't want to knock out some teeth. I tend to turn it sideways when the mouth is fully open and then rotate it midline. That usually sweeps the tongue out of the way for me. That barrel is designed not to lift the epiglottis. It's designed to be in the vallecula above the epiglottis. And then again, you kind of push and lift in the direction of my thumb. We don't want to rock back. We want to lift up. And that's going to push on that tissue and peel the epiglottis up like a trapdoor, exposing the vocal cords beneath. So it's dealer's choice. It's user's preference, what you're more comfortable with. But again, I kind of favor the Macintosh blade. The endotracheal tube itself, it's important to notice that it has a curve. A lot of pediatric airways are anterior. I always stylet it as well, so it's got a rigid wire in it so I can mold it to the shape I want. It has a balloon on the side that I can fill with air and test to make sure that the cuff pre-insertion is working. These cuffs do have a tendency to have pinholes in them and they can leak. So you always want to check your cuff ahead of time. You always want to mold your tube the way you want it to be and have your stylet in place beforehand. The size of the ET tube or the relative size of the patient comes with a mnemonic that helps you remember that. So it's age plus 16 divided by 4. So if it was a 4-year-old patient, for example, 16 plus 4 is 20 divided by 4. That would be a 50 ET tube. Some people will subtract a half for the cuff, and you should always use a cuff tube. So they may say this patient could use a 4.5 or a 5 ET tube. In terms of insertion, there's markers along the ET tube in terms of centimeters for depth. So depending on the size of the tube, and again, let's use our example of a 50 tube, we'd like to insert that 3 times the depth of the tube. So 5 times 3, we'd like to insert to a level of 15 centimeters at the lip or teeth, and then go ahead and confirm that our ET tube is in place. Now, speaking of confirmation, we do have one last piece of equipment that always should be available. So this is an Untitled CO2 detector. There are electronic ones that can hook up to your monitor, and they're chemical ones. This is a piece of litmus paper. It comes out of the package purple. Within 3 to 5 breaths, as carbon dioxide hits that paper, the purple color will turn to yellow. So purple that remains purple is a problem. Yellow means yes, you're in. Other things that you can do to confirm that the breathing tube's in good position: there may be vapor coming up and down out of the tube, adequate chest rise as you bag through the ET tube. You'd like to see the chest rise symmetrically. You can listen with a stethoscope and make sure there's equal breath sounds. And of course, you could get a confirmatory chest x-ray. But an Untitled CO2 detector is absolutely vital for preparing to have the airway instrumented and making sure you have all your proper equipment for airway readiness. So again, thanks for joining me. We'll have another tutorial that goes through the actual steps of intubation, but today it was really important to prepare and make sure that we're ready to instrument the airway. Thanks again, and welcome to Acadicus.